Hi, my name's David Evans from Bangor University, and I've had the pleasure of working with a group of practicing dental staff to develop this draft Perio pathway. We were asked to develop a straightforward overview of 12 months of care for patients and their perio needs. The purpose of this video is to provide you with an introduction, an overview, and examples of how this draft perio pathway would work. The group involved in developing it includes Rosie Newport, a dental therapist, Laura Parvu, a practice manager, Lowry Jones, an associate dentist, Sam Johnson, an associate dentist, and Lawrence Best, a practice principal. Our ask of you is to consider the pathway and discuss the questions we pose and identify comments, critique, and questions you may have. There's no perfect pathway, and this process seeks the views of staff working across the dental system. We will use the feedback to discuss with stakeholders across dentistry before sharing a first version for sharing more widely. On the screen now are some of the principles that drove our development of the pathway. I'm not going to go through them all, but what I'd like to do is just point out a couple of key aspects. Now, the first one is the pathway starts with ACORN assessment, and it starts once that's been undertaken. And of course, the focus of ACORN is on identifying and managing risks and then following that up with prevention. Patient engagement is also key and determines the progress through the pathway. But again, we'd welcome your thoughts on these principles. So before we look at the detail of the pathway, in its briefest view, the 12-month view of the patient pathway looks like this on the screen. There are 3 steps to it. The first one is establishing the diagnosis and the annual plan for that patient. The second ensures that the patient is now in control of their treatment and engaged with the process. And the third step is the complex treatment and improvement is undertaken with the patient over the 12-month period. What I'm going to do is hand over to colleagues who will talk you through the process in more detail, and each will start from the point of view of the ACORN assessment having been completed, and will illustrate the pathway for each risk category of patient.
Hello, my name is Laura and I'm a dental nurse and practice manager at the Valley Dental Surgery. I will be talking to you today about the green patient. Green patient, 12 months recall. Gwen is a 27 years old teacher with a very good oral hygiene. She comes to see the dentist for her 12 months checkup. There are no risk factors in her medical history. She is a non-smoker. She only drinks socially when she's going out with her friends. She never had dental treatment. She is only attending the surgery for her 12 months checkup appointments. After completing the ACORN form with all green and BPE 000010, the dentist reinforces the oral health advice and discusses other ways to prevent plaque, along with a referral to the oral health educator. The dentist is then asking Gwen to come back in 12 months' time for her next checkup and book to see the oral health educator. The patient is willing to engage and actively participate, keeping up with her appointments in order to improve the well-being of her oral health.
Hi, I'm Laurie. I'm one of the associate dentists in the group. I work part-time in a 2-surgery practice with 2 other dentists.
Next, we're talking about Amber for someone without periodontitis but who is at risk of developing periodontal disease. We're going to look at Gareth's case. He is a 38-year-old with a busy family life, a couple of children, and a demanding, stressful job where he works shifts. He doesn't always have the time to brush his teeth twice a day. He's sometimes just too tired, and he is partial to smoking, especially when he's at the pub having a couple of pints with his mates. His clinical findings would be a BPE of 2-1-2 across the top and 1-2-1 across the lowers, with generalised bleeding on probing. After the ACORN assessment, we would want to take further diagnostic examinations to ensure that Gareth doesn't actually have radiographic evidence of bone loss and to confirm our diagnosis of no perio. We would need to record a diagnosis of generalised gingivitis and acknowledge his risk level for developing periodontal disease in the future. We would then explain these findings to Gareth, including his risk level. In the past, this is the point where most of us would have likely spent a couple of minutes removing any calculus before sending Gareth on his way and reviewing him in 6 months. And this is where the pathway changes things. If Gareth had said, "Look, I'm too busy and it might never happen," he would exit the pathway without treatment and his periodontal condition would be reassessed at his next annual ACORN. If, however, Gareth said, "Oh no, what can I do about it?" he would be given access to the second step for Amber within about a month. At that second step, there might be removal of supra and subgingival calculus if it was necessary to facilitate prevention, and he would be given thorough and structured advice on what he could do to manage his disease risk and the areas of active gingivitis. For Gareth, that would be smoking cessation advice, detailed instructions and demonstration of how to use appropriate interdental cleaning aids, as well as his toothbrush. It would also be wise to remind him of the risks of not using those tools in the long term. His periodontal pathway would then terminate and he would be reviewed at his next annual ACORN.
Hello, I'm Rosie and I'm a dental therapist. I work across multiple sites alongside dentists, dental hygienists and dental nurses with additional qualifications. To represent an example of a patient's annual journey when presenting with code 3 BPE in the posterior sextants, I am going to talk about Gina. Gina attends the practice as a new patient. She is 37 years old and has no known medical conditions. She describes herself as a social smoker. At this initial appointment, Gina is informed of a diagnosis of localised periodontitis, stage 1, grade A, currently unstable, with a risk factor identified as smoking. The dentist performs an initial modified bleeding score of 63%. She is using a manual toothbrush and does not currently use anything to clean interproximally. The dentist takes horizontal bite wings at this appointment, which show bone levels and stage 1 loss. She receives tailored oral hygiene advice and is recommended to return in 1 week's time to see the dental therapist. At this appointment, the dental therapist records a modified bleeding score of 46%, noting some improvement and praises for this. They then reinforce the oral hygiene advice, the toothbrushing advice, the interdental cleaning advice, and also the smoking cessation advice. They also perform a gross interproximal scale to facilitate the patient's oral hygiene at home. The patient is then invited to attend in 12 weeks' time with the oral health education nurse. At this appointment, the patient has purchased an electric toothbrush, is now using interproximal aids every day, and has quit smoking completely. A modified plaque score of 17% is recorded, and the patient is praised for this improvement and proof of engagement. The patient is then recommended to return in 1 week with the dental therapist for an appointment to record a detailed pocket chart and to perform root surface debridement where necessary. Following a further 12 weeks, the patient then returns a final time in this year for a comparative chart. The patient's diagnosis at this appointment is localised periodontitis, stage 1, grade A, currently stable, with pocketing less than or equal to 4 millimetres and bleeding on probing less than 10%, with no bleeding on probing at any 4 millimetre sites. The patient's next appointment will be their annual ACORN assessment with the dentist. To discuss a non-engaging patient attending the dental practice with code 3 BP recorded during initial screening, we will again discuss Gina. Gina would follow through the same diagnosis route, would receive a modified bleeding score and be given tailored oral hygiene advice, smoking cessation advice, and offered an appointment in 1 week's time with a dental therapist. The dental therapist would again use this appointment to record a modified bleeding score, to reinforce oral hygiene advice that was given, to ensure the patient is happy with the use of any aids that have been recommended and allow time for the patient to practice with these aids as needed. They would then perform a gross scale to facilitate improved home care and oral hygiene. Gina would then again be offered an appointment with the oral health education nurse, whereby it is recorded that she has made no improvement with her oral hygiene and is not demonstrating any engagement with her treatment. She is therefore deemed to be a non-engaging patient and is informed that until a level of engagement is shown, she cannot progress forward to non-surgical periodontal therapy. She will then be seen again at her annual acorn assessment appointment with the dentist, where her engagement will be reassessed. It is important that at each contact with Gina, she is fully informed of her diagnosis and the responsibility she has in her own treatment. This should be clearly recorded in her clinical notes and continuing informed consent gained.
Hello, I'm Sam Johnson and I am an associate dentist here at Raven Road Dental Practice, and I am going to explain to you our red patients. So the first patient I will talk about today is the red non-engaging patient. So typically these patients have active periodontal disease but don't want to go ahead with the treatment that is on offer for one reason or another. And this is perfectly fine because people need to be in charge of their decisions regarding their own dental health. And this speaks to a wider aspect of the treatment pathway that is integral. That having engagement or the desire to have treatment is the most important condition that makes this pathway work for the benefit of all. So a typical journey for the non-engaging patient is that an exam and it's picked up that the patient has or had periodontal disease and a provisional diagnosis is made. The patient is then made aware of the gum condition and risks of doing nothing, and what treatment may entail is made apparent to the patient. The patient is then asked if they are willing to meet the conditions that are expected of them to ensure that treatment has the best chance of resolution. These conditions come in the guise of a key word: engagement. Engagement essentially means, does a patient want to actively try and improve their oral hygiene? And this may be brushing twice a day, flossing, possibly smoking cessation if they smoke. Although it must be clear that engagement is different for different people, and also it's about their overall attitude towards their dental health. Some people, put their hands on their heart and say, well, I'm not willing or cannot achieve a reasonable standard of oral hygiene, and they refuse treatment. And this is absolutely fine because the refusal is then documented and the patient is strongly suggested to receive oral hygiene instruction from a healthcare professional. We also need to be clear that refusal does not then condemn the patient to never receiving gum treatment, but they cease to be able to move forward on the pathway unless certain bespoke criteria for that patient, this bespoke criteria for engagement is met. And remember, it's all very specific to the patient. The patient is periodically reminded about their gum treatment and asked if they would like to move forward. As this has happened to me on a few occasions with my patients who were maybe not ready for active treatment one year and then ready to move forward in the next. The second type of red patient is the engaging patient. However, these people actively want to seek out treatment. So the journey of the red patient is similar to the non-engaging patient, where they have an exam and then they are alerted to the fact they have periodontal disease. It is at this point the patient is informed about what behaviours they need to engage in if they want to treat the disease appropriately. Such behaviours include brushing twice daily, flossing, and possible smoking cessation. Or in other words, how they need to personally improve their oral hygiene to enable the best chance of a good treatment outcome. In this particular scenario, the patient indicates that yes, they would like to treat the gum condition and therefore they move forward on the treatment pathway. From the perspective of a healthcare professional, further tests are required to create a working diagnosis. This includes measuring the gum pockets, any bleeding levels, and any relevant x-rays. These measurements are significant because they serve as a baseline that are then compared at subsequent appointments. The patient is then given extensive bespoke oral hygiene instruction, which is mandatory. It's important to note that all of this can be done in one session or multiple sessions by one clinician or a number of healthcare professionals. Flexibility is built into the pathway in this respect to cater for the vast diverse types of dental surgery setups found throughout Wales. Once all this has been completed, a review appointment is booked at 3 months' time, and in the meantime, the patient is required to clean their teeth really well for this period. Once they come back in 3 months for their review appointment, the baseline measurements are recorded again to see if there's been any improvements. Similarly, any stubborn spots can be identified and these areas can be given focused attention. It's also vitally important to check the engagement at this appointment. For example, have they listened and are they acting upon the home cleaning advice given 3 months ago? When assessing whether a patient is actively engaging or not, the clinician needs to use the nuance of the dental history taken at the review appointment as a guide, as there are no cut and dry ways to assess such engagement. For example, if a patient had never previously brushed their teeth and now 3 months later brushes only once a day, this can be seen as engagement despite the fact they were supposed to brush twice daily, because this demonstrates they have actively tried and therefore can be seen as engaging with the treatment. On the other hand, a patient can come back in 3 months and have completely forgotten about their gum condition, or their cleaning is exactly the same as before. This person can be seen as non-engaging, and a conversation needs to be had with the patient to whether or not it is appropriate for them to move forward on the pathway currently. Yet it is made clear to the patient that there is always scope for them to rejoin the pathway in the future if or when they are ready.
Well, thank you very much, Laura, Lowry, Rosie, and Sam, for giving us those overview of the pathway. Before I hand over to the facilitators, there are a number of questions which we've come up with during our working up of the pathway, and we'd like to open with those to start the discussions in your individual groups. You can find them on the screen now, but we'll also make them available to support your consultation session. We will really value and appreciate your feedback on the Perio pathway, and it will help the development and subsequent rollout of the pathway across Wales.